Hello everybody, my name is Etienne Cavagnac. I come from Toulouse. Today I will show you the technique I use for ACL and ALL reconstruction. For the ACL I will use the semi-T, fold in 3 or 4, keep attached and put inside. And for the ALL I will use the gracilis, fold in 2, with a 2 percutaneous incision. So first of all I will avert the graft. The landmarks are tibial tubercle, like that. And I can see the end of the tibial plateau there, and most of the time I can feel the graft there. And for the ALL, the landmarks are the girdis tubercle and the lateral epicondyle there. So I will do my incision proximal and posterior, and just posterior there.
As I'm very focused in the efficiency in the OR,
I would like to use my knife just one time, so I will first of all do my incision for the hamstring here, and I keep it. I do immediately the incision for the anterolateral ligament. I contact onto the bone like this. And here I put my finger onto the lateral epicondyle there. And I go onto the bone. So once you open the skin, just be sure that the incision is big enough to put everything inside. So I've got one here. I put a drape there here to protect the skin. And I pull as strong as I can to make it go out. It's really easy for me to catch it after that. With the full flexion, I can see the vinculus. You see the vinculus here? The vinculus there. I can cut that one. I can feel that everything is moving. I put the stripper there. Here we go. Okay, the stripper. Okay. That's nice. So those are my 2 grafts. Semi-T is the big one and gracilis is the second one. The semi-T will keep attached to have a double fixation on the tibial side, and for the gracilis I will just take out this one. In the real life I put vancomycin on that to have vancomycin soaking to avoid the infection, and I put it inside during my surgery so it stays clean inside the joint. So it's a left knee. I put my finger there. I can feel the soft point there, and I go very high to avoid the fat pad. Then I feel the medial condyle there. I go very low, and I go do for a small incision like that. It's I prefer to have different level of incision, so I can work in 3D. I will try to keep as much remnant as I can. Okay. So I don't touch that part. I go only here, close to the femoral footprint. Open here. So I love to keep as much remnant as I can. So as you can see on that device, the mark is very posterior, so don't put it too anteriorly. You go very posterior like that. Okay, nice, perfect. I will start with a 5mm or 6mm drill. I close to the context, so I do very slowly. And you see, I'm inside the ACL. I try to keep this very intact. I will control the position of the pin to be very, you see, I can go anteriorly, I can go posteriorly, and I try to have as much as I can until the top of the ligament. We can see the massage of the ACL. You see, we open that space. ACL massage. It looks like a sleeve. I'm inside. I try to go as far as I can. Okay, we can see the shaver there. So I will use my clamp to put the graft in that position. Okay, femoral device, please. Okay, I can see that my pin is close to where the graft was. Okay, let's go. So now I will check onto the skin, the length there. It's 55. I'm in contact with the cortex. 55, and I will drill 20 millimeters, 2 centimeters. Okay. Okay. So here the suture there. Okay. So I put a suture at the end of the tunnel there to know the length I need. Okay, nice. Onto the insertion of the sommity. Okay. Okay. And I can measure the length from the top to the insertion. In that case, it will be around 9.5 centimeter. Could you write this on the table? 9.5 centimeter. As I'm in that position, I will go for the FiberTak right now. So I let the camera in that position, so I can control if there is any convergence of the tunnel. Here we are. Okay. Here we are. Sorry. Okay. And it works well. Very hard. Okay. And I will do exactly the same on the tibial side. It's very important to understand here that the shape of the tibia at that part is like that. Okay. So I have really to be onto the bump. If I'm below, I will go down and it's not good. So you have to stay posterior to the guidus cervical. Imagine the guidus cervical is here, but stay on contact to the bump. So I can feel it, put inside. The guidus cervical is there. Here I'm too distal, and here I'm okay. Okay. Control that everything works. It works. So now I did all the tunnels. I did the two fixation device, so I just have to prepare the graft. 3.5 and 9.5. Okay, so I know the length in between the insertion and the end of the tunnel, and the length in between the insertion and the beginning of the tunnel. The graft is kept attached. I need the TightRope, please.
You have to increase the size.
The people that will help you for the surgery will put two grafts in contact, so you have to control the length here and the tension at the same time. Okay, close to it. Now the sommity is folded in two, here and here, to be sure that everything's at a good place. I will just fold in three in that case, because the tendon is quite big. So I have a sommity fold in three. So now we have a graft kept attached there, three advantages: vascularization, innervation, and secondary fixation. You put everything in that passing suture. Be careful to really hold the TightRope, the metallic part of the TightRope, with your finger here. Don't put it inside. First of all, you go with the suture, and then you put the TightRope inside. You will see it. Okay. I will control where I am. Okay. Could you come with me? Okay. I feel the cortex. I feel. Okay. Okay. Now it's good. Just by pulling on the. It's coming inside. Now it's down. It's inside. I'm not afraid to pull too much because there is a secondary fixation. You see the graft? The graft is here. Here it's inside and complete, and you still have the anteromedial attachment of the graft there. 15 degrees of flexion, please. And I go inside. I can feel the cortex. heard the good noise. This is the sumity there. The sumity is still attached there. You can see, so there is a secondary fixation. The tunnel is there. I can feel the screw, and the secondary fixation is there. So the ACL is done. So I have to pass underneath the ITB. So I have to feel where is the ITB, and I go down directly to my incision. So at the same time, I have the passing suture and the gracilis. Everything is here. Okay. So I will need another clamp, please. This will help me to put the graft down back to the tibia after. Okay. And then okay, the middle is almost, and I pass the graft inside both loop. Okay. Okay, you see the graft coming onto the cortex. Nice. Second one. Okay, it's perfect. And I can pull very strong on that. Okay. Now I have to go back with the other part. The good advice is you put a finger there. Is it this one? Okay, you can. Okay, and it's here.
So we have double strand gracilis.
Open the other one loop. I try. Put the pincer inside. Take both parts. Okay. Okay. And then full extension, please. Could you hold that one? Sorry. Yeah. Now we want step by step. Okay. You will see the graft here coming onto the cortex. Okay. Nice. Same second time. Okay, the graft is completely against the cortex. Okay, I can feel it. Okay, knife please, and you just have to cut. And you have your ILL done. So I was very happy to show you that combined technique about ACL and ILL. There is some points that I have to highlight. First of all, the biological aspect of the surgical technique. If you keep attached there, keep as much remnant as you can, you will improve the results. Then you can do the ILL with a percutaneous technique. You don't have to open too much. With a gracilis fold into that can improve the stability of your knee and improve the long-term results of your ACL reconstruction. So it's a very efficient technique. As you can see, you can do it very easily, and the ILL takes 5 minutes with if you are well trained. So it's not really a problem of increasing the length in the OR. So I really appreciate the technique. It's a straightforward technique, and if you have any questions, please ask your Arthrex rep.